Hello friends, today in the FGK series 26 I'm bringing you some information that all obstetricians and everybody who is performing prenatal screening must be aware of. Now this is on the non-invasive prenatal test or prenatal screening, which is a more appropriate word, that is NIPS. Now we have seen a huge surge in the NIPS tests in the last few years, and we must understand a few points about this because even as patients who are doing these tests and obstetricians who are advising these tests, we need to be aware about, of course, advantages, but also the limitations of the test and where to use it appropriately and correctly, right? And where you will get the maximum benefit out of the test. Now, NIPS is the cell-free DNA test, which has been in research for over 30 years, and it was primarily a test which was designed to detect Down syndrome in a non-invasive manner, right? So this is a test which was designed for Down syndrome, so obviously it's going to work best for Down syndrome. Now, why Down syndrome? Because Down syndrome is one of the commonest chromosomal abnormalities, as we know, and secondly, about 30 to 40% of babies with Down syndrome can look completely normal on the scan, and of course, as fetal medicine specialists and fetal imaging specialists, it's the biggest challenge for us to check for Down or confirm Down syndrome. Now, there was a lot of hoo-ha about NIPS test when it was first introduced into the market with huge, 5-figure costs. Now that has reduced. It's still in 5 figures, but it has reduced dramatically over the last several years, because over a period of time we have realized that NIPS can be used only in certain circumstances for certain conditions and not for everything. Now, huge number of studies which have been performed on NIPS have shown excellent detection rates for Down syndrome of almost 99.6%. That means if you have a NIPS test that is done, which is showing low risk for Down syndrome, then more than 99% that baby is normal. But this comes with a little caveat, because we need to be absolutely certain that the ultrasound scan is normal as well, or as close to normal as possible, because if you have any problems on the scan, any abnormalities or any significant markers like absent nasal bone, increased nuchal translucency, and aberrant right subclavian artery, these are strong markers, ventriculomegaly, these are strong markers for Down syndrome. So in these situations, it may not be as useful as it is projected out to be. Now, let us take a situation where you have a first trimester scan, and the first trimester scan has shown a reasonably good ultrasound scan, and then you've done the biochemistry, and that has also shown a low risk. That is a first trimester quadruple marker test or a double marker test. Okay, so you've combined the risk, and that risk has come down, and it is showing in about 1 in 1,000, which is what we now known as intermediate risk. Now, in these situations, if the parents want further reassurance, NIPS is a good test to opt into, and the detection rate is over 99%. Right? Now, let us look at another situation where you have a first trimester scan that is showing an 1 in 500 risk, but you have a nuchal translucency which is increased, which is above the 95th centile, say about 3.1, 3.2, and you've done a biochemistry which is also like kind of borderline, and then you have a 1 in 200, 1 in 300 risk, or 1 in 500 risk. Now, you have markers on the scan and you have certain markers on the blood test. Now remember, the combined test is the most time-tested test available in currently, and we have maximum amount of experience in that. In these situations, especially if the parents want confirmatory test, then it will not be appropriate to perform NIPT. Secondly, We know increased nuchal translucency can be associated with not just Down syndrome, but it can be associated with certain other chromosomal abnormalities or genetic abnormalities. And now we have a fantastic test called chromosomal microarray, which gives almost 8 to 10% higher yield higher yield than culture. And therefore, in these situations, it becomes even more important to do a chromosomal microarray and not an NIPT. An NIPT will be a suboptimal test in this situation because it will not cover for many things that actually an invasive test and a chromosomal microarray would cover for, right? So I think it's extremely important to put things in perspective, right? Assess what exactly are you looking for from an abnormal or a off the normal, I would say, or a deviation from a normal scan, and then decide whether an NIPT is good. If you're looking only for Down syndrome, it is extremely important to tell the parents that although this is a very good test for Down syndrome, it is a 99% accuracy and not 100%. If the parents want a confirmatory test, you tell me, doctor, whether my baby has got Down syndrome or not. If this is the question, then it is imperative that you tell the couple that a definitive test is only by an invasive test and not by an NIPT. Now, the other situation is microdeletions and certain other genetic abnormalities. Now, please remember that these tests have not been validated by the NIPT. So if somebody is looking for 22q microdeletion or a Prader-Willi syndrome or some other genetic syndrome, then doing an NIPT is totally incorrect test to do. So in these situations, you should not do an NIPT. Now, when the results of NIPT come, there are 3 types of results that we get. We get majority of the times a low risk result, which is very reassuring, not confirmatory, but reassuring that the baby is very unlikely to have any major chromosomal problems. I would presume by now you have understood that these situations this test should be done where essentially the ultrasound is normal or very, very close to normal, or where you have really minor markers which you're just, doing further testing to reassure the couple. Now, if it is a low risk, it's very reassuring. If it is a high risk, okay, now it does not mean that the baby definitely has got Down syndrome. Now, remember the cells that come out of the, which is drawn in the prenatal sample, are not strictly fetal. They are mixed with fetal and placental cells as well. So you can have certain situations where you have abnormal cells in the placenta and normal cells in the fetus. So in this situation, it is imperative that you should do an amniocentesis to check the fetal karyotype. And that situation, if the fetus karyotype is normal, very likely this is a placental mosaicism. Right? Now, it's not infrequent that you have you're testing for Down syndrome and you have a high risk for monosomy X or some of the sex chromosomal aneuploidy or a triploidy, and that's the results you get on an NIPT, and then you're thrown off the mark because you're not even looking for monosomy X or a Klinefelter syndrome, and then the result says, oh, it's high risk for sex chromosomal aneuploidies. Now, in that situation, again, it's imperative that we have to do a invasive test, more so if the baby looks structurally normal, right? Now, because it is again placental mosaicism with these aneuploidies is not uncommon. That means the placenta has got these abnormal cells, but the fetus is essentially normal and fetus is unaffected. Now, the third type of result that you will get is a no-call result. No-call result is because there is a very few fetal cells, and therefore the laboratory is unable to give you a result based on the current NIPT sample, and majority or almost always the laboratory will ask for a repeat sample. Now, repeat sample means it's another 2 weeks for the results, but also remember the repeat sample has got a higher failure rate. Now, when you have a no-call report because of a low fetal fraction, some laboratory takes 4% as cutoff, some laboratories take 2% as cutoff. So you need to check with the laboratory what exactly is their cutoff for fetal fraction to give a no-call report. Now, in the no-call report, you must do an amniocentesis, because that's the only way then you will be able to be sure that the baby is otherwise normal chromosomally, right? Then only you can complete the test. So whenever we counsel parents to do an NIPT, it's not at all enough just to write an NIPT in your prescription and send the parents off, because you need to explain these 3 types of results that the parents are likely to get, and what is the further action that has to be taken in these situations. Then only the test is complete. Pre-test counseling with NIPT is absolutely mandatory. Now, my dear friends, remember, NIPT and IPS test is largely driven by the industry. It's the laboratories which are pushing the tests on the clinicians, and clinicians must assess it correctly, scientifically, and see whether this test is really valuable to my patient or not, and then only offer it to the patient, and not get tempted by the beautiful big claims that is being made that this is all in all, this is a panacea of all tests and this is the best test, etc. We still have to largely depend on ultrasound before we advise an NIPT, 2, interpret the NIPT, and 3, when we get the results of the NIPT, again it is important to take into consideration what the ultrasound scan findings has been. So NIPT has to go hand in hand with ultrasound as a complementary and not as a replacement for ultrasound. I hope this clarifies a few doubts at least on NIPS and NIPT. I have done NIPT in twins as a FGI series. I think it's number 2 or number 3. So if you're interested, you can go back and check on that as well. Thank you very much and have a lovely day, and stay safe because COVID is increasing and we have to be careful, and don't forget your masks. Okay, bye-bye.